End-of-life care, palliative care, talking about decline, those are concepts that are not as glamorous. It's easier, almost always easier, to talk about doing something than to talk about the implications of a diagnosis and what if you do something and not something else. Those can be very time-consuming processes, but you have to understand where they're coming from and what their belief is about their disease process, what their family experience has been. You have to hear that in order to be able to develop a plan that makes sense. I first became interested in hospice and palliative care soon after I moved to Pinehurst in 1991. I had been fortunate to work with some physicians during my oncology training who were very proactive in trying to manage symptoms that patients had as they were taking chemotherapy or as their cancers progressed. And so I started working with hospice and began to see just how very important that was to patients and their families in terms of not only managing their symptoms but also optimizing their quality of life for whatever time they had remaining. I appreciate the quality of the care it provides to the patient. It does a better job of treating the patient and the family as a unit of care than the health system does. Through the years, I have continued in the position with hospice, but have watched palliative care emerge not only within oncology, but also within other medical specialties and as a discipline in its own right. Palliative care is designed to move past that hospice population to a population that is not yet hospice appropriate, but is facing a chronic and potentially ultimately life-limiting illness, and to apply that same concept of alleviation of suffering, be it physical, emotional, biopsychosocial, or spiritual. And so I see an expanded role for that, particularly as our population ages. If we as a healthcare system and we as healthcare providers are going to truly provide the best patient-centered care, then this is an important component.